ladies and gentlemen, and I convey my thanks to Dr. Vivek Gupta for a very extensive introduction, very kind introduction, and for giving me this opportunity. So why this Berlin heart? Basically, it's a device to support circulation left ventricle or right ventricle till the heart recovers or till the heart is transplanted. And why I am here to present this case in front of you, that this is the first of a kind case done in India. And it was a 2-year-old child which was referred to us from Dubai for management of heart failure and for a possible heart transplant. So I will just in brief take you for this journey along. So what is actually a Berlin heart? Basically, Berlin heart is a ventricular assist device, or in a layman language we call it artificial heart, because it takes over the function of the heart, and artificially the machine, it supports this function for whatever time we desire. And because this device is developed in Germany, in Berlin, and the headquarters is in Berlin, so this is famous as a Berlin heart. So as you can see in this picture that this is a baby, and you can see these two little pumps which are connected through big cannulas to this baby, and these are basically the heart pumps which are supporting the circulation. So it's a ventricular device. You can see there are two devices, one is for the left ventricle, the other one is for the right ventricle, and it is an external pump. Now, 2 weeks back, I have implanted an adult patient with a left ventricular assist device, which comes by name of HeartMate 3. Now, the third generation is in use. That patient is also waiting for heart transplant, but he was very sick. So, because it takes time for a donor heart to become available, 6 months, 1 year, or maybe more, and that person could not have survived without doing anything. So 2 weeks back we implanted with a left ventricular assist device, but because he was an adult patient and that device is totally fitted inside the chest cavity. So, but the children, no single device is available so small which can be fitted inside the chest cavity of children. So that's why these are the external pumps which are used in children. And what is the good thing about these devices? They can support the full circulation. Whatever 1.5 liter, 2 liter flow, cardiac output the child requires, it can support the full amount of circulation. And because now the organs are getting adequate blood, so the end organ like liver, kidney, brain, they their function stops deteriorating, and those organ functions are maintained. Nutrition is maintained, muscle mass is maintained, and even when the child is active, so we can increase the cardiac output by doing some setting, so that the increased cardiac output can be delivered while the child is active. This is a pictorial representation. You can see this machine, which is basically the drive unit, and through the cables, it is connected, drive cables, it is connected to the devices, and the device is connected through big cannula which are like 1 inch thick to the heart chambers. So there are 2-3 drive units are available depending on the requirement, if the child is in ICU or child is mobile. This is a little detailed representation of the device, pump, heart pump basically. So there is a chamber, there are 2 chambers. So on the top you can see this is the air chamber which is connected through a drive line to the drive unit. So the drive unit, it pushes air into the chamber and draws air out of the chamber. So there is a membrane which is between the upper and the lower chamber. The lower chamber contains blood, so which is connected to the heart chamber through an inflow and an outflow cannula. So inflow cannula brings blood to the chamber, and the outflow cannula, it takes blood to the desired pulmonary artery or aorta. And then through this membrane, the blood is being pushed, drawn out, pushed, drawn out. So it's a typical pulsatile flow like a normal heart flow. So regarding this patient came to us in March 2023. She was just short of a few months of 2-year age. She was having dilated cardiomyopathy, and she had recurrent episodes of heart failure. We evaluated her and we registered her for transplant, and as you know that heart and lungs are the two organs which cannot be taken from a live donor like liver or kidney. So NOTO is the National Organization for Tissue and Organ Transplant. It's a government of India body which coordinates, manages cadaveric organ donation and allocation. So in March she was registered, but she suffered 1 or 2 episodes of decompensated heart failure in the meantime. So we used to admit her for 3 or 4 days, give her some inotrope diuretic. She used to get better and we used to discharge her. But then in month of May, she got admitted, and this time she did not get better. So the inotropes, she was on like 3 or 4 kind of inotropes: dobutamine, milrinone, adrenaline, and even vasopressin for some time. And still she went on going down. Then we had to put her on ventilator support also. And after a few days of ventilator support, we were not able to wean her, and then we had to do a tracheostomy. So now she was tracheostomy dependent and inotrope dependent. And it is not very easy for a 2-year-old child to get a heart. You know that as such heart donation in India are very rare, and from where to get such a small heart. Though 2 years back we had implanted we had done a heart transplant in a 5-month-old child, and the heart was retrieved from a 18-month girl donor from Gangaram Hospital only, but that was 2 years back, and that is also a record. In Asia, not a transplant has been done in a 5-month-old baby. That baby is doing fine, and the family has shifted to US last year. So so she was inotropic dependent, she was ventilator dependent, and then she developed sepsis, liver failure, and her kidney function going down. This is how the chest X-ray looked, and you can see that how big the heart and the lungs are flooded. So these were the problems. She had severe low cardiac output, decreased urine output, lactic acidosis, septicemia, even fungal was positive, and all the blood other parameters were going down. So it was decided that she needs some circulatory support, and without that, all the organs, they will keep deteriorating, and ultimately she may die in a few days. So this system was, because this is a very unique system, only available, it is not freely available in India. So we had to get a special license to import it from the government, from the Director General of Drug Controller, and it was specially imported. The device cost was like 3,50,000 euros. So she was put on this biventricular support on 29th of July. And though she was septicemic, she had a liver failure, her platelets counts were 19,000, and all those things which are basically otherwise are contraindicated for this kind of external mechanical support, but we had no choice. And miraculously, by next week and 2 weeks, she started improving. So this is the picture of the child. You can see these 2 pumps. On the left side, you can see this is a pump which contains dark blood. On the right, it is a blood which is more red. So this left pump is connected to, is bypassing the right ventricle, and the left pump is bypassing the left ventricle. So this cannula, it is coming blood, bringing out blood from the right atrium, and then this pump is pumping it into the pulmonary artery, so that the right ventricle is bypassed. And likewise, this left side, this outflow cannula is bringing blood out from the left ventricle, and it is taking blood into the aorta, so that the left ventricle is being supported. Uh, you can see this membrane which is moving and the blood is moving. This is how it works. So, because she was totally on mechanical circulatory support and slowly she came off inotrope, she came off ventilator, the tracheostomy was removed and she started eating well, gaining weight. This is when we used to take her for her daily sojourn outside to the sun because she was otherwise continuously in the ICU. So, like this, so her mother, her father, our ICU nurse, and this you can see the console which is connected to these pumps and is driving it. Then luckily on last month on 27th of November, we got a matching heart of a 5-year-old donor girl from Mumbai. So we flew to Mumbai through a charter jet, got the heart, and there was a green corridor which was created in Mumbai and Delhi. So in Mumbai, the hospital was around 12-13 kilometers away from the airport, which was covered in flat less than 20 minutes. And same here from the airport to the Apollo hospital, the 20-kilometer odd distance was covered in 17-18 minutes with the help of Delhi police, who created very graciously the green corridor on a Monday working day in the peak traffic conditions. So she has recovered well after the heart transplant and she is about to be discharged in a few days. And this is the picture after the transplant, when the devices they have been removed. So she is now on a standard regime, triple drug regime for immunosuppression, which is low dose of steroid, tacrolimus, and mycophenolate or Celcept, and some supporting medication like Septron and antiviral. And she looks good. She is eating well and growing well. Thank you very much.
So I think I had summarized in the beginning, but he has given a talk about this, a very important talk about this. Any comment, Amit, would you like to, regarding heart transplant?
Sir, I just want to ask, sir, regarding the immunosuppressants, what is the duration like patient has to eat?
So the patient have to be on immunosuppression for lifelong.
Lifelong immunosuppression?
Yeah, though the day, like for a first year, the dose is little high, but after first year we bring down the dose. And steroid for the heart transplant can be tapered off after 1 year. So there will be only 2 drugs, tacrolimus and mycophenolate, but they have to be lifelong.
Lifelong.
What is the maximum, as of now, maximum number of years the heart transplant patient has lived? Recently there was a news actually.
So there was a, in 94, when the first transplant was done in AIMS, and that patient was alive after 20 years.
For 20 years?
Yeah.
Recently,
He's still alive.
He's still, overall, the worldwide, what do you have any data?
See,
maximum number of years somebody has lived.
I don't have that data, but general survival after heart transplant is 3-year survival is close to 85%, 5-year survival is close to 70%, and 10-year survival is close to 60%.
A 40% patient will succumb within 10 years.
But it includes all the patient, like with all kind of morbidities, mortalities, and so many problems. But otherwise, these patients are who will not live more than 6 months without a transplant.
So maximum you can pull on for 10 years.
No, 10 year is general rule, but 20, 30 is not a problem.
Something else need to be there. Some artificial heart which can be used for a.
Even HeartMate 3, which I mentioned, this is a 10-year
destination therapy.
Yeah, as a destination therapy, it can last more than 10 years or more.
So of course it is of course somebody is a misfortune to have a requirement for the transplant, but of course the life is evolving, continuous medical technologies. And thank you, Mukesh, for this talk and your energy level for the transplant.
I want
You
to
have
ask a
You have to
question.
remain awake for more than 36 hours. Continuously you have to work, getting the patient, transplanting the patient, getting the patient, hibernation, survival, getting is also huge work, I know. It is not a simple angioplasty which we do in half an hour or 25 minutes, or bypass surgery which is done in 3 hours time. It's actually a huge work and a lot of enthusiasm required to do and perform the procedure. Any comment? Is somebody on the Zoom?
Yes,
No.
I want to ask a question.
Okay, good.
Sir, as you told that the availability of heart is a issue because it is a single organ in the body. So I want to ask, is there a national program or is certain work being done on 3D printing of organs, particularly 3D printing of heart or xenotransplantation in India?
So in India, the need of the hour is basically at the moment is awareness about cadaveric or brain dead organ donation.
that is not my
I am coming to
question.
that. I am coming to that. Okay. And all over world, still not a single organ has been developed by 3D printing which can work. So there are a lot of work which going on abroad. Obviously, India, we cannot do this kind of
No,
work.
your,
It requires a huge resources and it's a basic science and universities have to do it. So nowhere, in India it is not being done. Other thing is what the need of the hour is to, because in Chennai or in Tamil Nadu, there are 200 cadaveric donations are done in a year. In Hyderabad, another state, more than 150. In Maharashtra, which started very late, like 5-6 years back, more than 100 donations. Gujarat started 3 years back, more than 100 donations. And in Delhi, the first heart transplant was done in Delhi in 94. And what is the donation rate in whole of North India? 10 to 12 per year. And while we have a huge scope of cadaveric organ donation, the public is not aware, and even the doctors are not basically willing for it. They don't counsel. And the government set up, private, government, all are basically very pathetic attitude regarding this organ donation. So Delhi, we can easily reach 200 donations in a year, but we are not doing anything about it. So we need to increase the awareness, spread the awareness, educate the public, educate the doctors. The doctors have to have that aptitude and attitude to counsel the family at the time when we encounter such kind of patients who are brain dead, but their organs are okay, so that they can be counseled and retrieved and help it. So one organ donor can help 2 kidneys, 2 liver, 1 heart, 2 lungs. 6 patients can get a new life from one organ donation, one organ donor.
That was not my question.
Okay.
That was not my question, cadaveric donation. I was asking about why is 3D printing of organs not
doctor,
been done in
because your
India?
question is hypothetical.
No, it's not
It is
hypothetical.
like if I am talking about
because
reaching moon, so you
3D
can talk
printing
कि
has
Jupiter
been
पे
done
क्यों
in
नहीं जा रहे हैं?
US. Tendons have been 3D printed there.
No, nothing. No organ has been printed, 3D printed and used ever, including in an animal. If you have that information, it is a fake information.
No, it is not fake information.
Yeah.
Xenotransplantation has been done in a individual and he lived for 2 months in US. In
So
New
that
York.
xenotransplantation has not become successful, number one. And second, the cost of that pig is very specially developed by that company. Okay, and the cost of that pig, $500,000 US for that pig, and which is unsuccessful. So these are experimental procedures requiring huge resources. And so that's why in Indian context, it is still a hypothetical question. We cannot talk about it clinically.
Thank you. Thank you, Mukesh. I think I have to small change. Dr. M.K. Das is online. Actually, we are getting late. I know you are hungry. So can we bear with us for another 10-15 minutes so that we can talk about the next session before going for lunch? Because then he's another program. He's a past president of CSI. Dr. Das, can you hear me? Dr. M.K. Das? Yes, yes.
Can you hear me?
Yeah, it is perfectly. I can see you. And Dr. Abdul Rashid Khan from Pakistan is also online as one of the panelists. Dr. Abdul Rashid Khan? I can see him logged in. He just spoke that he will be there.
muted.
Okay, let me introduce Dr. M.K. Das. So we are having this 20th edition of IECR conference. Dr. M.K. Das has been the past president of the Cardiological Society of India. He has a huge interest. He's based in Kolkata. Again, the last day could not come, but his presence is important for us. He is having a huge interest in heart failure. And he has been talking all through the world, including outside India, many places invited, ESC, the nation conferences where he has been talking about heart failure. His topic today, as you know, heart failure is a very important topic because we know the ejection fraction, either diastolic heart failure or systolic heart failure. We know he will talk about that. So heart failure is getting more and more common, especially with the elderly population. I'm sorry for delaying the lunch, but it's important. He's already online. The topic is definition, classification, evaluation, and risk scoring of heart failure. Dr. Mrinal Kanti Das, a very, very respected figure in Kolkata and in India.
May I share the screen? May I share the screen?
Yeah, yeah, you can share the screen.
Yeah. My slides are visible.
Yeah, perfect, perfect. And you are also visually very handsome.
Still hands up.
Thank you very much. Thank you very much, Dr. Vivek Gupta. You are very close to my heart. And your ICR also I am attending for quite some time, and really thankful to you for giving me the opportunity. I am giving the basic lecture on definition, classification, evaluation, and risk scoring of heart failure. I won't talk about the the management of the problems, but definitely the whole lecture will usher into a concept where you can deduce your management principles also. It's a global burden. There is no doubt about that. I'm not going into the detail of the statistics, but it's increasing day by day. Now, for a long time, the definition of the heart failure has been there, and really speaking, there have been many changes in the definition. But I like this it's the students, the Bronwall's 1980 description, a pathological state in which an abnormality of cardiac function is responsible for the failure of the heart to pump blood at a rate commensurate with the requirements of the metabolizing tissues. As you know that this is a very old definition, but still holds good. But of late, there have been many changes, and we got the universal definition where it was labeled as a syndrome and or functional cardiac abnormality. So structural or functional cardiac abnormality. And along with that, at least one of the following, that is the elevated natriuretic peptide levels, or objective evidence of cardiogenic, pulmonary, or systemic condition. I'll talk something about all these things. Apart from this, there are also stages of heart failure, like stage A, stage B, stage C, and stage D, where in stage A, basic risk factors are present like hypertension, diabetes, metabolic syndrome, alcohol abuse, and all these. In stage B, already the risk factors are there, and there could be heart failure evidence, along with the heart failure hospitalization, evidence of rheumatic heart disease. In stage C, you are taking tertiary care with different methodologies, and stage D, of course, the rehabilitations is the crux of the management. Now, there are also clinical classification of acute heart failure, as I have already anyways, with acute heart failure, hypertensive heart failure, pulmonary edema, acutely decompensated chronic heart failure, right heart failure, as well as cardiogenic shock. and the various incidences and various importance of different of these elements or components are given over here. I am not, again, in the interest of the time, not going into the detail of it, but definitely cardiogenic shock may be a part and parcel of. Now, over a period of time, over a period of time is almost since 1864, there has been more emphasis on the ejection or ejecting fraction, which is defined as EDV minus ESV. EDV means end diastolic volume, ESV means end systolic volume, into 100, which gives the more or less the ejection fraction. And there have been different description from Herbert to Nylin, Gustav to Falks and Bronwald to Elliot Lane, who defined this ejection fraction in the right perspective, and ultimately they are being frequently used in the definition of ejection fraction, which can extend from heart failure with reduced ejection fraction to heart failure with preserved ejection fraction, and in between there could be heart failure with mid-range ejection fraction, which is defined between LVF between 40 to 49, in preserved ejection fraction more than 50, and reduced ejection fraction.
There's some network issue at your side, I think.
Am I audible now?
Now you're audible again, yes.
Yeah. I don't know why you actually didn't hear me, but I was talking about the importance of the ejection fraction, and there is a long history of ejection fraction. It could range from reduced ejection fraction.
You have to share your
mid-range
PPT
ejection
again.
fraction.
Actually, your PPTs are not visible. You have to share your PPT again.
Oh, sorry. Just a minute. Yeah.
Okay,
Can
yes,
you see
okay.
my slides?
Yeah, perfect.
Okay. Yeah. So I was talking over here, and their deterioration and all these things can happen and may go forward or may go backward. There are other definitions or other kinds of heart failure also, like HF, then uncontrolled ejection fraction, worsened ejection fraction, and recovered ejection fraction. And all these have got different connotations. Now, this is a new concept, phenotyping beyond ejection fraction. This has come because of the fact that the GLS, which is measured by spectral tracking analysis of 2D echocardiography as well as the strain imaging, where we found that even with the low ejection fraction, there could be some other ejection fraction, and even with the preserved ejection fraction, that is ejection fraction with higher ejection fraction level, which is called preserved ejection fraction, there could be low ejection fraction. And similarly, the myocardial tissue characterization also could be defined with cardiac MRI, and they could define the different kind of the heart failure classifications. This is another new kind of concept regarding the heart failure classification based on the clusters of heart failure therapy, cluster A, B, C, D, E, and these have been shown with the different kind of treatment schedule that are being applied in the heart failure management, and these are the clusters. Now, the evaluation starts from clinical to ECG to X-ray and all these things. And symptomatologically, the shortness of breath, cough, PND, orthopnea, fatigue, palpitation, disease spells, all these are very common. And there could be signs also in the form of raised JVP, third or fourth sound, pulmonary congestion, edema, hepatomegaly. And these are some of the characteristics of the heart failure, which are more common with either preserved ejection fraction or in reduced ejection fraction. And these are shown here with the female. The more females are affected by preserved ejection fraction. Similarly, the BMI is more in preserved ejection fraction. Coronary artery disease could be also another thing with the preserved ejection fraction. So these on the left side are more or less associated with preserved ejection fraction, whereas on the other hand, the reduced ejection fraction could be associated with more with diabetes and sometimes without any particular illness. And these are already talked about. And this is the algorithm. After getting the history, physical examination, and laboratory evidence of BNP, you can triage the patient and go for the echocardiography and then redefine whether it is diastolic heart failure. This is an older term, as it is now known as the heart failure with preserved ejection fraction, and also systolic heart failure, which is an older term for the present heart failure with reduced ejection fraction. ECG is a very, very basic test, and there are various manifestations like heart rate increase, then P wave duration, then SCT wave abnormalities, left ventricular hypertrophy, left bundle branch block. These are all indicative of heart failure, and atrial fibrillation is a very common abnormality and is a deadly duo for heart failure with atrial fibrillation. Left bundle branch block is another one which causes desynchronization, and it's of important clinical significance. Same way, the cardiothoracic ratio or chest X-ray gives a lot of findings, and Cardi's B lines are very, very important. It's almost asked to all the students of cardiology that Cardi's B lines are indicative of the left ventricular ejection, left ventricular diastolic pressure rise or left or pulmonary capillary wedge pressure rise more than 14 millimeter mercury. Same way, the interstitial edema or Cardi's B lines could also be seen, and they are indicative of 14 to 18 millimeter mercury of pulmonary capillary wedge pressure. And when there is frank edema, you are having actually pulmonary capillary wedge pressure or the LVEDP in case of left ventricular failure more than 20 millimeter mercury. And this could be another picture of alveolar edema. The BNP, the rise of biomarkers is again very, very important. And out of this, I'll mention about the three biomarkers importantly. One is the NT-proBNP, second is the SST2, and third is the troponin, which could be in the form of troponin T, troponin I, or high-sensitive troponin. And the BNP, troponin I, SS2, all these have got the prognostic implication also, and there could be increased mortality with the rise in NT-proBNP as well as the TROP-I. And multi-biomarker approach is a very, very commonly used approach in management of heart failure nowadays. The imaging techniques are also very important, and ultrasonography gives a very important indication about the Cardi's B lines in the form of the vertical lines. Apart from this, the echocardiography, cardiac bar, cath, SPECT, MDCT, PET, all these also can give a lot of information. Echocardiography is definitely important. And as you can see, it not only can give you information about the hypertrophy and dilatation, but also gives evidence of left ventricular systolic heart failure or diastolic heart failure with different manifestations. And it sometimes unravels the mitral stenosis, which may not be picked up by the stethoscope, and also mitral regurgitation with severe left ventricular dysfunction. There may not be any audible sound, but they can be picked up by the echocardiography. And with rest and exercise, you can get a lot of information. Two kinds of tests are there: 6-minute walking test and modified Bruce protocol or stress marker for perfusion test can give a lot of information. And these are some of the informations and which can be picked up by echocardiography. And CT is another mode of investigation which can give a lot of information about the left ventricular structure, right ventricular structure, venous anatomy, coronary arteries, heart transplantation, and also arterial positions. And what is the side effects of this is that large volume of iodinated contrast medium is required and may be harbinger of contrast-induced nephropathy, and that is why many times they are not very much used. But definitely, if they are given, if we are given a choice in intermediate type of probability for coronary artery disease, we should do the CT coronary angiography. It can also give indications about the various device therapy, and we can pick up many of the informations by CT scan. And apart from this, the MRI also can pick up many issues. And as you can see by the list, which is giving a lot of information, especially with the late gadolinium the imaging, it can give a lot of information regarding the subendocardial ischemia, then fibrosis, differentiating between the HOCM or HCM, and also various structural disorders or granulomatous disease like sarcoidosis, myocarditis, adenosine, Anderson Fabry disease, Chagas disease, because these diseases are treatable, and if you can pick up them by MRI, you are going to definitely manage the show in a different way. And these are some of the slides for the cardiac MR, and they can give information about the scars, which is a very important harbinger for sudden cardiac death, and that might actually indicate about the AICD. And even you can pick up iron overload as well. And I already talked about the sarcoidosis, and constrinctive pericarditis, another important cause which can give information and can give the differentiating point. Right heart failure and right heart catheterization and left heart catheterization also can pick up many of the conditions, and you can predefine the heart failure and plan accordingly whether you should go for the treatment with invasively or non-invasively, and thereby you can go for the specific management. I'm not going into the detail of the risk scoring for heart failure with reduced ejection fraction, QART risk score, and various factors are evaluated like LVF, LVSD, etc. And you can also pick up the risk scoring for heart failure with preserved ejection fraction as defined by ESC, and if the scoring is more than 5, you can tell that this is definitely a heart failure with preserved ejection fraction, and you can predefine the heart failure and redefine the heart failure from systolic to diastolic heart failure, and thereby you can offer best treatment or guideline directed medical therapy. Thank you very much. For patient hearing, this is a slide to show you the digital technology is also taking important role in phenotyping the various heart failure cases, and this is another pathway by which we can predefine the heart failure. Thank you very much.
Dr. Das, a scintillating talk actually. We were already late for the lunch, but I can have one. Any comment from Dr. Dua regarding heart failure? Dr. J.M. Dua is a clinical, he's a physician here, or anybody else wants to comment something?
I must.
Dr. Khanna is here. Okay, I was waiting for him. Dr. N.N. Khanna is there.
I must congratulate Dr. Das for such a wonderful lecture. He's almost put everything so clear for everybody. I'm sorry I couldn't come physically. I was stuck in the hospitals. I'm joining virtually, but I was listening to Dr. Das' lecture, and it reminded me of, one of the most precise and most unique lecture, which actually covered every aspect of the topic, and it made things very clear for the audience. And I must tell you, Dr. Das is a crusader for AI and cardiovascular disease, and he's brought it to the CSI, and I'm sure you can see what his vision. You can see it being fruitful in another 3-4 years. That is the time when all these things will be so common, and it will be used. And he's brought it right in the time.
Thank you very much, Dr. Khanna, for your good comments.
Thank you, Dr. M.K. Das. We'll have a physical presence later on. And a very happy New Year to you, and thank you for taking your time. We're a little late in the lunch. We'll have
Happy
break
New
for the
Year to
lunch.
everyone.
And some questions we'll
advance.
take up on telephone. Your
Thank
number
you.
will be shared to people who will be
Sure,
happy to ask
And
some
for
questions.
all everyone's information, actually the last topic, that is the artificial intelligence, I am going to talk it in the European Society of Cardiology conference at London. So if anybody actually likes it, then definitely it will usher into a new era of management of heart failure. Thank you very much.
At that time, what we'll do, we can have your talk live from there, and we can be putting it on our something like live so people, audience in India can speak, can also hear, something like CSI can do for you. Thank you very much, Dr. Kadas. Now we have to really go for lunch, and I will request Anand Khanna to come physically after a while. Thank you. Thank you, Dr. Dua. You have to stay back after lunch, and you have a session after that also. We quickly go for lunch because here the rules are that they have to finish by 3:15. The kitchen will be closed. So please grab your lunch as soon as possible. And we come back at, what is the time now? 2:45. Sharp 3:30 will start. Sharp 3:30. Thank you very much.
Recording stopped.